Some great stuff also happening in DaRe2THINK. I think Alistair's going to catch up with things just after Karina, just to let you know about some really important changes that we're making. We've listened to all your comments and suggestions over the last year or two about the DaRe2THINK program and how we can make it even more easier for you guys as well as patients to join in, and also the troubles that you've had in the past with some of the legacy IT systems we were using. You'll be glad to know we're moving to an entirely new system, a much quicker system, and I'm sure Alistair will give us an update on what to expect and when those sort of changes are likely to happen, and also how you can continue to get involved in getting new patients and new practices and so on recruited to DaRe2THINK. So without further ado, I'll introduce Karina Bunting. So Karina's a fellow at the University of Birmingham with the British Heart Foundation. She is an echocardiographer, so a cardiac physiologist, who's one of a rare breed in the world, where she's actually an academic, but still doing her clinical work. Karina helped to design and lead a really important clinical trial, which we led from in Birmingham, but was a global trial. And I'll leave it to you, Karina, to go through some of the thoughts and learnings from STEEER-AF. Thank you.
Great. So thank you so much for inviting me today to present at your webinar. Thanks for the introduction, Deepak. I'm very proud today to present the results from the STEEER-AF trial. So just a few disclosures and funding about the trial. So what we all know that we're seeing more and more patients with atrial fibrillation in our clinical practice. And for the patients themselves, atrial fibrillation is a terrible burden on them, and also it places increasing pressure on our healthcare services. Due to atrial fibrillation's varying nature and the fact that depending on the patient's individual characteristics, how it affects treatment, makes it a difficult condition to manage. However, with guideline adherent care, we can improve the outcomes for patients with atrial fibrillation. And furthermore, by providing education for patients, we can improve their quality of life and reduce adverse outcomes. So what we don't know is actually in clinical practice, are we adhering to the guidelines? And is there a fair way of assessing this? Secondly, we don't really know if we provide education to improve guideline adherence, is this effective? So as shown on the wheel on the right, we start with creating new, robust, evidence-based guidelines. We identify areas in which we need to provide education to implement these, and then we define local learning objectives, and then we create education programs to enable healthcare professionals to understand the new guidelines and implement them in their practice. But we don't really have a robust way of actually measuring whether this education works to improve guideline adherence. So the STEEER-AF trial was designed to determine whether a focused education program for healthcare professionals could improve guideline adherent care for patients with atrial fibrillation in terms of stroke prevention and rhythm control. The design was an international multi-center cluster randomized trial taking place over France, Germany, Italy, Poland, Spain, and the United Kingdom. Each hospital center acted as a cluster. So when the centers were randomized, the healthcare professionals taking part in the study were either randomized to the interventions, everyone in that hospital would receive the education program, the intervention, or if they were randomized to control, the healthcare professionals would receive no further education. They'd undergo their normal education and have as part of their training. In total, we recruited 1,732 patients, and our main outcomes were the co-primary outcomes of the number of patients receiving total guideline adherent care for stroke prevention and a number of patients receiving total guideline adherent care for rhythm control. We also had some secondary outcomes in which we wanted to determine the proportion of guidelines attained, guideline adherence in terms of anticoagulant specific recommendations. And we also wanted to determine how the patient felt their care improved by measuring their care according to the integrated AF management score. And we also wanted to determine whether they felt their quality of life improved with the intervention, measured by the EQ5D5L questionnaire. We also had some intervention-only outcomes in which we measured how the learners interacted with the education programme. Guideline adherence was determined by a predefined algorithm, which myself and the statistician created. We basically went through every single class 1 and 3 recommendation for stroke prevention and rhythm control, and created this decision tree to determine guideline adherence. In terms of the patient flow, so each centre had to recruit 25 patients with AF, and these were recruited by the healthcare professionals taking part in the study. So these are patients they would have seen as part of their routine care. The principal investigator in charge of the centre would use the clinical information from their healthcare records to complete a case report form, which we would then use to determine guideline adherence. So determine what patients were receiving guideline adherent care at baseline. The patients at this point also completed the quality of life questionnaire and the integrated AF management questionnaire. Once baseline was complete, the centres were randomised. And so in centres randomised to the intervention, the healthcare professionals in that centre would then enrol in the 16-week education programme, which was consisted of 8 weeks of online learning supported by a national trainer, and then 8 weeks in which they discussed between them how they'd implement what they learn into clinical practice. And then in the control arm, the healthcare professionals continued as normal with no further education. At 6 to 9 months, the same patients returned and were seen by the same healthcare professionals. And at this point, we measured guideline adherent care again, and this is where we collected the co-primary outcomes. Finally, at 18 months, the principal investigator for each centre remotely recorded any major clinical events the patients had during the 18 months they took part in the trial. So like I said, we recruited 1,732 patients. The demographics were well balanced between the 2 trial arms. Over a third of the participants were women. In terms of the type of AF, the majority of patients had paroxysmal AF, and most patients had AF for less than a year. As expected, a lot of the patients had several comorbidities, with 69% having hypertension, 22% with diabetes, 10% with previous stroke or TIA, 9% with previous myocardial infarction, and almost a third of patients having a diagnosis of heart failure. In terms of baseline management, the majority of patients were receiving an oral anticoagulant and some form of rate control. However, in terms of rhythm control, the number of patients who had undergone some form of rhythm control procedure or were currently receiving any antiarrhythmic drugs was proportionally lower. So for the baseline results, we were surprised to see a lower adherence level than expected, with only 61% of patients receiving complete guideline adherent care for stroke prevention, and only 21% of patients receiving complete guideline adherent care for rhythm control in terms of class 1 and 3 recommendations. With regards to the intervention, there was a good interaction between the learners and the online education programme. A median of 9.2 hours was spent online, and there was a demonstrable improvement in their knowledge with their pre-education MCQ score improving by 7% to their post-MCQ score, so 65% to 72%. And the majority of learners interacted with their expert trainer as well throughout the programme. The median follow-up was 7.7 months, so the patients were seen within that 6 to 9 month period. So in terms of results, so for stroke prevention, although both arms improved, there was no significant difference in the number of patients receiving guideline adherent care between the control and intervention arm. However, for rhythm control, in the intervention arm, there was a significantly greater number of patients who received guideline adherent care in the intervention arm compared to the control arm. In fact, the number of patients receiving complete guideline adherent care in the intervention arm improved by 51%. In terms of our secondary outcomes, so looking at the guideline adherence for anticoagulation specific recommendations, there was no significant difference between the two arms in the number of patients who were receiving guideline adherent care. In terms of the proportion of guidelines adhered to, for stroke prevention, again, there was no significant difference between the two arms. However, for rhythm control, there was significantly greater number of patients in the intervention arms who had a greater proportion of guidelines recommendations adhered to rhythm control. And finally, in terms of how the patients felt their AF care was provided by the healthcare professional, in the intervention arm, the integrated AF management score was significantly higher. So suggesting that patients felt that their care was better in the healthcare professionals, for the health professionals who receive the education. So just to go over a few limitations and strengths, this was very much a pragmatic trial embedded within normal clinical practice. So we're unable to account for varying levels of education at a local level. We avoided any observational biases by the PI, who is independent of the management of the patient, completing the case report forms. At baseline, we included in the randomization procedure, baseline adherence in the minimization procedure for randomization to avoid bias. Generally, the hospitals are medium to large, and we only focused on the must-dos and must-not recommendations, the class 1 free recommendations, to avoid any sort of grey areas. A limitation is we've noticed that obviously there was a discordance between, there was a great improvement in rhythm control in the intervention arm, but not for the stroke prevention. Recommendations. This may be due to a lower baseline adherence than expected. So in conclusion, the bottom line is that we spend a lot of time making these guideline recommendations, but if on the shop floor in the hospitals and in our clinical practice, the healthcare professionals aren't adhering to them, then this isn't going to improve care for the patients. The STEEER-AF trial has shown that after a short online intervention for healthcare professionals, patient-level adherence for guidelines for rhythm control has significantly improved, and the patients themselves also felt that they received better care for their AF. The STEEER-AF trial has ultimately shown that a targeted education programme for healthcare professionals can improve guideline adherence where there are substantial gaps in their implementation. We are currently in the process of analysing the 18-month outcomes, so we're hoping to present these soon. Thank you very much for listening. I'm happy to answer any questions.
Great, thank you, Karina. Fantastic talk. It's open for questions to Karina, so you can either go in the chat or there's a Q&A, whichever you find more helpful. While you're all starting, I guess the question will be is how much, Karina, can we extrapolate? Because as you mentioned, for pragmatic reasons, this was done in health centres. I mean, there were some, I think, community health centres as part of that, but the majority, as you mentioned, were kind of medium-ish hospitals.
Yeah,
so how much can we extrapolate that into primary care? And also another question is then, is this relevant to primary care in the UK?
So as the learners, although they were sort of secondary, tertiary healthcare centres, the learners involved in the study weren't cardiology specific. There were general medics as well. So I think this could be extrapolated into primary care as well, and how we can improve practice.
And not just doctors?
Yeah, so we also had a lot of, quite a high proportion of advanced nurse practitioners as well, and I think some physician associates as well.
Okay, and then there's a question from Catherine. how long was the training course, and do you think it's realistic for clinicians to attend?
So the total course was 16 weeks, but you had the flexibility to interact with the online program whenever suited you. So obviously the total online interaction was 9 hours, not 16 weeks. So the healthcare professionals just log in when they can, so they could do half an hour here and there, and then pick up where they left off at another time. I completely appreciate that time allowed for training isn't incorporated into your routine schedules, but we're hoping we try to make it as focused as possible. And then there's optional for extra reading, but the actual online education program we made as focused as possible. So hopefully by having all the training in one place, we can make it more efficient for healthcare professionals rather than trying to search around.
Great. And so just on following up on that then, so what's the translatable elements here? I mean, so this has been done in a trial, but I think what you've shown is where there are potential gaps, then you can do these kind of short educational approaches that can have, quite substantive impact. What's the next step, I guess? How do we, what do we need to do to kind of make that more widespread and then to involve primary care in that problem?
I mean, I don't know what the funding behind would be, but it would make sense for me. So for organizational bodies such as the European Society of Cardiology or similar bodies within the UK, I should offer this education to practices over the UK. And ultimately, if you can improve the healthcare professionals' education and then improve guideline adherence, then this will impact on patient care and hopefully, at the end result, reduce the pressure on NHS services. So if the sort of governing bodies can provide this education, and I think the benefits definitely there.
I guess the other question was about that disparity you showed between stroke prevention, but actually, the number of patients who were adherent to their anticoagulation was exceptionally high, 90% or so. Now that might probably not be expected to be as high in primary care, perhaps, but still, I think, it seems as though most practitioners across the UK have taken on the kind of advances in DOACs in particular, do you think?
Yes, I think, like I suppose DFAC sort of referred to, that it was already very high, so it's kind of hard to improve what's already very high with education. So I think we're in primary care, if you can make this even better, then this should improve the adherence to stroke prevention recommendations.
Yeah, there's a couple of other questions coming in. I'm mindful of time, so maybe we can tackle these somewhat offline as well. But there's one question about how you decided which guidelines to follow, particularly, the comment here about the fact that, NHS care, both secondary and primary, is in a bit of crisis right now. So are there specific areas, I guess, that were important?
So we used the ESC class 1 and 3 recommendations, which were specifically for stroke prevention and rhythm control. I'm aware that there's obviously variation and differences between, for example, what's suggested in NICE, but we just used the class 1 and 3 recommendations from ESC.
Right. Okay. And then just the final one, just to keep this still on track, is are there any other alternatives to improve AF guideline adherence that could be researched in future, such as clinical system prompts? Now, I think the answer to that, David, is actually what we're currently doing in DaRe2THINK, which is a nice segue, I think, to what Alice is doing, because I think the potential here is to use the health data in a much more intelligent way. And so as we're doing in DaRe2THINK, pulling that data across to identify who potentially could get anticoagulant therapy in this case, in DaRe2THINK. Of course, if the trial then becomes successful, that's some sort of thing that could be rolled out to practices so that they would have that capability, as part of a kind of NHS focus on this. So yeah, I think there are definitely opportunities to do that, and also to bring in what we're doing in DaRe2THINK, which is a fantastic segue. So thank you, Karina, for your time.
Thank
Great
you
to
very
see you,
much.
and good luck with the paper and subsequent follow-up. So I'll hand over to Alistair for the last sort of 8 to 10 minutes, just to highlight us on some of the changes, and hopefully to excite people again about getting new patients enrolled again.
Great. Thank you very much, Karina, and thank you, Deepak, for that introduction and lovely segue into my quick update into DaRe2THINK. Just to remind those here, and to remind any new people that have joined this webinar for the first time, actually, what is it that we're trying to achieve in the DaRe2THINK trial? So the DaRe2THINK trial was designed to answer a call that was put forward by the National Institute of Health and Social Care Research, and it was designed to actually look how we can embed research into routine NHS care. By doing that, we'll be able to reduce the burden on both NHS staff and patients, and hopefully open up research into the wider community. The DaRe2THINK is an exemplar of this new national delivery method, and it is looking to recruit GP practices and patients to a trial targeting a key health issue of how to prevent stroke, thromboembolism, cognitive decline, and vascular dementia in patients with AF, while also developing a future-proof trial pathway that can be used to answer key questions in a disease-agnostic way and help improve adherence to international and national guidelines. We're looking at recruiting low-risk patients with atrial fibrillation and randomising them to receive early intervention with direct oral anticoagulants, or to carry on with current NHS guideline care. So, to start off and actually summarise the achievements that we have at the moment. So DaRe2THINK is currently actively recruiting general practices and patients from across England, and we have already seen a number of these amazing achievements. We have made research involvement easier for GP practices with rapid onboarding processes and dedicated online learning tools to allow over 600 GP practices from across the country to sign up to be involved in this opportunity to potentially prevent vascular dementia. Our ability to remotely screen over 13 million patients for trial eligibility removes the need for individual practices to do complicated database searches, and has potential implications for actually future work, as Deepak alluded to, in terms of embedding guideline therapy in patients. We've had an amazing uptake of patients so far, with over 1,000 patients now recruited. This recruitment has come from over 300 practices spread across the country, and in practices that have never taken part in research before, showing that actually if we innovate in the way that we deliver research, we can get it to a wider audience. Patients can take part in this study completely remotely, enabling new patients to take part in research that previously haven't had the capacity or time to do that. As Deepak mentioned, we are continually working to improve the study, and have now successfully piloted a new and improved screening platform to support trial practices. This new platform has improved the efficiency of screening and will be rolled out to all practices in the near future, with communications to be sent out to our practices by the end of the month with how that will happen. We're not stopping there at all. We have approval to recruit until December 2027, and have over 1,000 patients still left to review in recruited practices. This is a call out to all practices taking part in the study. Book a meeting with a member of our team, and we can support you on all your trial activities, answering all questions that you might have. We are absolutely still looking for practices to be involved in this exciting opportunity. So if there's any members of staff from practices that are currently not signed up to the DaRe2THINK study, or actually practice staff that work with practices in other PCNs or are part of a federation, and you think DaRe2THINK would be able to be rolled out into those practices, then let us know. Scan the QR code on the slide there. Book a short meeting with a member of our team, and we can discuss how we can get your practice or other practices in your PCN involved in the study. That just leaves a couple of minutes for questions, but thank you for giving me the time to discuss the DaRe2THINK trial and for taking your time out of your lunch break on a Friday to listen to our webinar.
There's a couple. I don't know if you can see the Q&A.
Yeah.
Alistair? Yeah.
Yes. Yeah, great. Thank you, Naresh. I absolutely will contact you and have a chat about actually new practices taking part. Thank you, Ruth, for asking our most common question about whether we can recruit EMIS and System 1 practices. So at this very moment in time, we are still limited to only EMIS practices in the DaRe2THINK trial. We are working on changing this. Every time it's asked, we get closer and closer to using System 1 practices, and we're hoping that potentially towards the end of this calendar year or the start of next calendar year, we will be able to pilot the use of System 1 practices. But I absolutely, if you've got System 1 practices in your PCN, in your federation, get them to sign up to CPRD, a very short joining form, and those practices will be then ready to be part of the pilot if we do manage to roll that out. Great. An anonymous attendee, can the CRN help practices support recruitment as capacity in our practice is a bit of a struggle? Absolutely. I'm sure many of you are aware that the CRN has recently changed to become the RDN, the Research Delivery Network, but absolutely it's in our protocol, and many RDN teams are supporting practices to recruit to the study. If you want help from your local RDN, reach out to us and we can put you in touch with the right people at your local RDN and see what support we can get out to your practice to help with recruitment.
Maybe that person can just, because their name didn't come up, maybe they can just reply with an email or something, and Abby can get in touch with them and link them up with their RDN support team.
Great.
You've got a couple more questions coming.
Yes. Thank you, Helena. Will there be any publications to share the design of this unique trial? So we already have published the design of the trial. That was published in the Journal of Europe, the European Journal of Digital Health. That's the words I'm looking for. And that shows actually the methodology that we've used to design the trial. We've also recently published the background reasoning of the trial in Nature Medicine, and we're absolutely happy to share those with practices if needed. Finally, would we need to do the full 4-hour GCP to sign up? Absolutely not. So DaRe2THINK, we are really looking at bringing research to new practices and new staff members. If you want to take part, actually, we provide a short 6-minute GCP training as part of our trial training. That will mean that actually that covers you for the DaRe2THINK trial, and it can help you get involved, get used to research, with the view of then doing the full GCP later for future trials if you want to take part. Great. Well, I think
I can't see any more questions, but do keep them flowing into the DaRe2THINK email address, and then the team can handle those. Thank you, Alistair, and thank you. Karina's already just left, but thank you all for attending. It was great to see you all. Please do keep recruiting. Just remember that we need to sort of double the number of patients we get over the next year or so. So there's lots of patients still available to screen, and if you need any help whatsoever, the team are getting really quite adept at sorting those things through. And as I said, look forward to the next iteration between May and the end of summer, depending on where your practice is, to really kind of move to the next step and really get a very much more efficient system that doesn't have the same capacity problems we've had in the past. So thank you all for your patience with that. Still do please keep using the existing systems until we've switched you over. But in the meantime, thank you all and have a good weekend.